Bipolar affective disorder. Bipolar affective disorder is a serious lifelong mental health condition that causes extreme shifts in mood, energy, activity levels from highs to lows, significantly affecting daily life. This actually shows two poles, first of mania and then of depression. Then again, the person becomes normal. This is actually a mood disorder. Manic patients are loud, violent, and aggressive. Manic episode is of less than 7 days or equal to 7 days. Manic patients are highly energetic. Even 6 to 7 persons are unable to control. These patients have elated mood, increased interest levels, increased energy, decreased need for sleep, increased appetite, attention concentration deficit, disinhibition. For example, they take off their clothes publicly, they make inappropriate jokes, and this happens because their frontal lobe feedback is absent, overspending, and grandiosity, such as hallucinations, religiosity, etc. Okay, so there is an important point that a person with depression feels that I am very useless, but on the other hand, a person with bipolar affective disorder thinks that I am very special, and also their sexual needs are increased. So, a person with hypomania has no delusions, no hallucinations, and if the person is having delusions and hallucinations, as they're also present in bipolar affective disorder, but the person has low mood, then you can say that it is depression with psychosis because the person with bipolar affective disorder is having elated mood. If a person is behaving this way with no past medical history, then it is actually a manic episode. But if a person with a past history of depression or mania is behaving this way, then he is having bipolar affective disorder. Differential diagnosis for bipolar affective disorder could be HIV induced psychosis, head injury, steroid induced psychosis. Informational care model is as follows. Introduction. Introduce yourself to patient, ask patient's name, and then the level of education of patient. Give information about the disease, such as name, symptoms, duration, causes, genetic, brain changes, environmental, 85% incidence, dopamine is increased, also structural changes, and financial stressor. Then comes prognosis, which is highly relapsing and remitting. Mechanism of transmission is genetic, it is not contagious. And also educate patient about care. Then comes treatment. It follows biopsychosocial model, BPS model. If a person is having bipolar affective disorder plus current episode of mania, then we are going to follow this protocol. Admit the patient, give IM intramuscular antipsychotics, for example, haloperidol plus IM antihistamines plus IV benzodiazepines, which is continued for 3 to 7 days. When the patient becomes stable, shift the patient to oral antipsychotics and also give prophylactic mood stabilizers. First line is lithium. Lithium can also cause lithium toxicity. Then, for this purpose, we monitor TFTs, RFTs, and lithium levels, thyroid function test, and renal function test. It can affect thyroid and renal system. This monitoring is done for 3 to 6 months. This is an MCQ point. Side effects of lithium, GI side effects, and neurotoxic. Second line mood stabilizer is valproate. Side effect includes weight gain, tremors, alopecia, edema. This triad is very important. Weight gain, tremors, alopecia. Third line mood stabilizer includes carbamazepine. Bipolar affective disorder with depression is treated with selective serotonin reuptake inhibitors with antipsychotics. Psychological component of BPS model uses cognitive behavioral therapy, CBT, sleep hygiene, such as sleep cycles should not be disturbed, medication should not be stopped suddenly, and also avoid emotional environments such as a wedding, funeral, avoid drugs. Social component of BPS model works by catering their religious beliefs and also clearing their myths, stay neutral, for example, no bias in religious beliefs, etc.